Okay, we are recording.
Hello, my name is Kelly Nguyen.
I'm Kishana Mohammed. I'm Angel Kalou.
And I'm Atia Gilani.
And the topic of my presentation is America's opioid epidemic. Over the past few decades, growing concerns have been circulating over the current epidemic that has swept the American nation, costing an alarming amount of American lives, the United States opioid crisis.
As the number of patients and citizens receiving access to these opioids defined by Harvard Medical School, a graduate school consisting of physicians and scholars dedicating their studies on medical research, as a, quote, drug class that includes the illegal drug heroin as well as powerful pain relievers such as oxycodone and morphine, has continued to rise, and it has led to an array of detrimental consequences.
Moreover, the abuse of these drugs has led to over 16,000 deaths, all within the year of 2016, with 40% of these deaths due to prescription opioids.
As a group, we decided that the best solution to the opioid epidemic is implementation of the state's prescription drug monitoring program, also known as PDMP. PDMP is an electronic database that tracks controlled substance prescriptions in the state. PDMPs provide health authorities timely information about the patient's prescription history and behaviors that contribute to the epidemic. It also helps facilitate a targeted response by informing their prescribing decisions. Although findings are mixed, evaluations of PDMP have illustrated changes in prescribing behaviors and has decreased substance abuse treatment admissions. Some states have implemented policies that require providers to check a state PDMP prior to prescribing certain controlled substances, and these policies have significant potential for ensuring that the use of PDMPs are maximized. When pharmacists dispense controlled substances to patients, they should have to enter this prescription into the state PDMP in real time. This maximizes the utility of the prescription history data with significant implications for patient safety and public health. PDMPs can also be used to send proactive report to authorized users to protect patients at the highest risk and identify inappropriate prescribing trends. According to the Health Affairs Journal, PDMPs have been associated with an average reduction of 1.12 opioid-related overdose deaths for a population of 100,000 a year after its implementation. However, Ohio was an early adopter of mandating the use of a comprehensive PDMP. Pharmacists in Ohio are required to review a patient's PDMP history before dispensing a new controlled substance prescription. The rule also requires pharmacists to review a patient's report every 12 months and to query Ohio's PDMP if any red flags are present. Since the implementation of Ohio's PDMP, it has observed reductions in opioid prescribing and doctor shopping. With the mandatory use of such a program being successful in Ohio, pharmacists should advocate for similar legislation in their own states. Dr. Leonard Paluzzi, a medical epidemiologist in National Center for Injury Prevention and Control, and Daniel Ster, a director in public health law, they evaluated the impact of state drug programs and laws by comparing New York and Pennsylvania. New York has not been as affected by the recent drug overdose increase rate, while Pennsylvania ranked top 3 in drug overdose rates in 2006. In their study, New York's PDMP monitors Schedule 2 through 5 controlled substances, and they investigate their prescription records for illegal activity. Pennsylvania, on the other hand, only monitors Schedule 2 prescription drugs and didn't evaluate its data until recently. These highlighted differences between New York and Pennsylvania shows that opioid overdose rates might be related to the regulation of PDMPs. Nevertheless, this solution is not pitch perfect, as it has some limitations. Each state has its own personal PDMP, so patients determined to deceive the system may do so by crossing state borders in states without effective data sharing, or they can report false information when registering with the hospital. There's also possibilities that a patient's health information can be hacked. So, for PDMPs to be successful, further improvements are needed to improve accuracy and to fix all weak points in its nervous system.
It is fundamental to evaluate this epidemic through a scope of scientific research and advancements. Addiction as well as overdose fatalities are fueled by the increased availability of potent synthetic opioids such as fentanyl. New and improved approaches are needed to prevent and reverse these risks. Alternative treatments and non-opioid medications should be prioritized. In a scientific research study conducted by Dennis Gisuda, a chemist at Astria Therapeutics, he discovers a new mass unit opioid peptide receptor, or MOP, called AT121. This bifunctional morphine-like analgesic is designed to block the addictive effect of opioids while simultaneously relieving chronic pain. This is achieved by stimulating the MOP, which makes opioids effective in treated chronic pain, as well as the nociceptin receptor, which inhibits the addictive effect of opioids. This can be put into comparison with other painkillers such as oxycodone and fentanyl, which only act on the MOP, making the user susceptible to developing physical dependence and also the wide range of side effects. Moreover, the same research study constitutes that it is 100 times more potent and stronger than morphine in relieving chronic pain based on an experimental trial determined on monkeys. However, the limitation should also be carefully considered. Because this breakthrough opioid alternative is fairly new, its success cannot be promised. Being discovered only about a year ago, more trials need to be ran in order to determine its effectiveness. Thus, because PDMP has been implemented in 49 states dating back to 1918, its potential to combat this national public health emergency is far more promised and progressive as opposed to AT-121. Until then, the future of our generation lies within the hands of scientists and medical professionals in order to promise a healthy future for America.
As Kelly already stated the problem, my alternate solution is to provide naloxone to opioid users to reduce overdose mortality in the United States. According to Sharon Stonecliffe, in the harm reduction approach, take-home naloxone provides users with an intervention opportunity who are currently unwilling or unable to abstain from substance use. First off, what is naloxone? Naloxone hydrochloride is an opiate receptor that is routinely being used by emergency responders to reverse opiate overdose. In the article by Public Health Reporter, they describe an initiative to provide pre-filled naloxone dispensers, especially to those who are currently receiving overdose-related education and training, so they can directly provide education to them and to enable them, if necessary, directly initiate overdose reversal and opiate overdose among their peers. The USMA Department of Health and Mental Hygiene, they're currently providing education to people who are in jail. They're currently providing referrals to special exit and prevention plans for people as part of discharge planning, so that individuals receiving overdose education and training could benefit from it while they're inmates of jail. They can still receive naloxone as following their release. Furthermore, challenges limiting widespread dissemination of this strategy reflect the complex effort required to intake and promote and implement this uniquely regulated public health initiative. The limitation to my solution is that naloxone only provides assistance to the overdose. It can't be used to prevent opioid addiction nor reduce the risk of deaths. This limitation emphasizes the importance of prescription drug monitoring programs because it not only helps reduce overdose death, but it also prevents opioid addiction, but while my solution does not.
While opioids are given as treatment for chronic pain, they are highly misused and difficult to reduce dependability. With this being the case, there has been a tremendous toll on the environment because of the amount of waste that has been discarded and has led to it disappearing in nature. Waste such as needles, plastic containers, and chemical contamination has been making an appearance in water supply, animal bodies, and habitats. As explained by the National Center for Biotechnology Information, many groups of organisms that affect human and animal health, which are targeted by opioid pharmaceuticals, have a crucial role in the functioning of Earth's ecosystems. Therefore, opioid pharmaceuticals have caused a negative outcome in aquatic and terrestrial organisms. A potential solution could be for the federal government to enforce further training for physicians and pharmacists to incorporate cautious dispensing, prescription, and disposal of opioids. This effort would also need to include health professionals to educate patients on the risk of addiction, methods of withdrawal, and how to properly discard of unwanted opioid medication. Recently published by the National Institute on Drug Abuse, the White House has released a strategy for responding to America's prescription opioid crisis. Federal agencies have established rehab programs educating about the dangers of opioid misuse and strategies to properly prescribe, dispense, and dispose. The limitation for this solution is that these efforts do not guarantee opioid users will take the educational advice from health providers, nor will the opioid pharmaceutical pollution be guaranteed to decrease or be remedied. This limitation emphasizes the importance of PDMP as this program has proven to decrease the amount of misuse of opioids through supervision and monitoring.
In conclusion, the prescription drug monitoring program is the ultimate solution to the opiate epidemic in the United States. Addiction, overdose, and deaths caused by non-prescription medical use have risen dramatically over the last decade. Evidence continues to suggest that prescription drug monitoring programs are effective in improving clinical decision-making, reducing doctor shopping and diversion of controlled substances, and assisting in other efforts that could curb the prescription drug opiate epidemic. And here's our works cited. Thank you.
All right, nice job. I am going to start with Kelly. Describe how the content of the team presentation was changed as a result of your group's discussion.
After group discussion, we decided to ultimately shift the focus of the environmental perspective. So Kashan's initial approach was mainly focusing on an individual's social environment and how it affects them and influences them to turn to opioids. However, we wanted to view the problem on a wider scale, so we decided to shift this and turn it to how the opioid epidemic affects the ecosystem through the dispensing of the syringes, the needles, and also the chemicals that are being released into our water systems.
Thank you. Kashan, in what way did you improve your ability to work with a group as a result of this project?
As a result of this project, we were able to demonstrate good communication, and with this, we were able to set up times and locations to work on a presentation effectively, and this created an efficient work ethic for us, and we were able to find multiple limitations to our solution, and we even took the step to narrow them down from 4 to 3 to avoid exceeding the time limit.
Angel, in the future, what change would you make to your group's norms? How would you expect that to improve the team presentation?
In the future, a change I would want to make to our group norms is being more open and more inclined to read each other's individual research. So that makes us know, that puts everyone on the same page on what research is being presented. Because at first, when we started meeting up for the TMP, we didn't read each other's IRR. We just talked about the research. But it caused a lot of misunderstandings because I heard what they said, but I didn't understand it. But after we decided which solution should go into the TMP, when I read the IRR, I was like, oh, this makes more sense. So the change I would make to our group norms is being more upfront with reading each other's IRR and understanding each other's research.
Okay, thank you. Would you describe an argument from one of your peers' individual reports that made you think differently about your team's solution?
One argument that made me think differently about our team's solution was Angel's our solution on PDMP, because my research revolved around naloxone that only provides assistance to the overdose, but it doesn't really help people get rid of addiction. But PDMP is a program that that made me think differently, because I thought this program could not only prevent the overdose death, but also can also help people to get rid of their addiction. And programs like PDMP, Prescription Drug Monitoring Program, can save the lives of many people and stop the opioid epidemic in the United States.
Thank you very much, ladies.